Hi, I'm Shaman Harper, and today we're having a roundtable discussion about three topics when it comes to mental health. The first topic is like the medical model of mental health. You know, what does that look like? What are the pros and cons of that? The second topic is the venture capitalist model, and we'll kind of go into the definition of that in a minute. And then lastly, our follow-up, or our last topic, is going to be on what does quality mental health care look like? And we have a really cool panel of professionals here today. Everybody here owns a therapy practice, and everybody here works in this industry and provides phenomenal service to their clients every day. But like I said, I'm Shaman, and I am co-founder of Harper Therapy. And we have Rebecca Williams, who, you can wave, yep, there you go, who is the owner of Inland Empire Couples Counseling in Southern California. She heads up a team that specializes in high-quality relationship counseling. We also have Erica Labuzan Lopez. She's a licensed marriage and family therapist, supervisor, a licensed professional counselor supervisor, and the owner of Center for Couples Counseling in League City, Texas. She specializes in couples therapy, infertility counseling, postpartum mood and anxiety disorders, and is an expert in minimalism concepts and how they apply to the therapeutic model. And then we have Tabitha Westbrook. She's a licensed marriage and family therapist, a licensed clinical mental health counselor, a licensed professional counselor, and a certified clinical trauma professional. She owns and operates Journey in the Process in Wake Forest, North Carolina, and she and her team specialize in complex trauma, especially domestic abuse and coercive control. And then last but not least, we have Yolanda Harper, and she is a licensed clinical social worker, a TEDx speaker, and is co-owner with me of Harper Therapy, a practice in Tampa, Florida, and we help our community heal from trauma and the way trauma impacts families and relationships. So let's kind of dig right into it, and let's start with the medical model, right? We're using some broad kind of terms, but the idea here is someone's looking for therapy, and what does all this mean, right? So when we talk about the medical model of mental health, we're talking about traditional insurance billed model of health. Most of us are familiar with how this works. This is how we go to the doctor pretty much every day, right? You go, your insurance company, you pay a copay, your insurance company pays the rest of a contracted rate to a provider, right? And there's some good and bad with that. And I think our first topic we'll talk about here is maybe how this kind of discourages people with mild or moderate problems from seeking mental health care. And maybe, Rebecca, you can kind of talk about that a little bit.
Yeah. So I think that when we require something to have a diagnosis, that we maybe the medical model only really catches the people whose symptoms are really severe. And we may have other people who have mild to moderate symptoms. They're just at the very start of some kind of problem where mental health care or where therapy might help them. And they may be discouraged from seeking therapy and getting services that would really help them because either they don't qualify for a diagnosis and so the insurance won't cover them, or they have this kind of block to overcome, but I'm not really that bad. So maybe my symptoms don't yet feel like it's bad enough that I have to go to a doctor, but I'm anxious all the time, or I'm, feeling kind of depressed, or maybe there's some relationship problems starting to show up. And those people might not seek mental health care when it's always housed under the umbrella of a medical establishment or a doctor's office. Or I know in managed healthcare settings, like your symptoms would have to be pretty severe for your primary care physician to say, I really think that what you need here is therapy. And I know for my specialty in particular with couples therapy, it's often tricky to get insurance to cover couples therapy, because if what you have is a relationship problem, your medical insurance doesn't consider that to be a healthcare problem, and so they might not cover it. But if your only option is for getting therapy is that you have to have your insurance pay for it, then people either just don't get the help that they need, or they and their therapist have to go through these kind of tricky, jump through some hoops to get the insurance to to cover their therapy, or almost like make up a diagnosis, which isn't ethical, and I think most therapists wouldn't do that anyway. But it presents these real challenges where I prefer a more preventative look at mental health care, where people if we can get them help when their symptoms are mild to moderate, we might not ever need to have the severe level of treatment, and people might not need to suffer as long if we're shifting the way that we think about who needs to go to therapy and how we pay for it and how we identify even who needs that help.
Right. Any other thoughts, comments with that, guys? Ladies?
Spot on.
Totally
agree.
Yeah.
Mm-hmm.
I mean, it almost kind of feels counterintuitive though, right? Like, I have this insurance benefit, I should be able to use it, but because of the way the model is built, it's almost counter to me actually seeking and getting help and turning me away from help.
And it doesn't work the same way in mental health realm that it does in the medical field.
Right. Right. I mean, it's easier, like when you go to mental health field, right, or like not mental health, like regular doctor, and you have this thing, and they can easily diagnose it and move on, right, and or work through it, right, like getting to a diagnosis. It's a little more complex and a little slower, right?
Diagnosis isn't always helpful,
Right.
you know, and it's a requirement for insurance to even cover anything, like Becca was saying, that, you know, we label these things as disorders without any recognition of how those skills have actually helped someone survive serious traumatic events in their lives. And we're not even honoring that. It's sort of a reductionistic perspective on humanity and makes it really challenging for folks. And those labels that we give them as a diagnosis and submit to insurance follow them throughout their lives and throughout other experiences. And then when they're applying for jobs or, you know, trying to adopt, those things come up even if they've recovered fully. And that could cause problems where they say, no, you can't adopt a child, even though in a million different ways they're a fantastic fit for that. But they had PTSD from, you know, a traumatic experience or series of traumatic experiences in their own childhood. And now they're suddenly disqualified. But they've been recovered and healed for such a long time. And that's not taken into consideration. It can also make your insurance premiums go higher and things like that. So there's a lot that goes with it that I think folks don't necessarily realize. And that creates a barrier to care for people.
Right.
I'll also say that if you have reached out to a therapist on your insurance panel and left a message and not gotten a return phone call back from that clinician, that is because even though insurance companies are netting insane amounts of profits over these past couple of years, especially, that has not trickled down to providers. And so these therapists have had to stack their day full of appointments, and that doesn't allow for them to have time to return phone calls, which we all should be returning phone calls because it takes a lot for someone to reach out for help. But that also poses a problem because in order to pay their bills, clinicians are having to see more and more clients.
Sure. Going back to this, like, this diagnosis piece, right, Tabitha? I mean, you're talking about things that could really affect people down the line, right? You're talking about things that that aren't so easy when people first come into your office, and it's not like you're going to diagnose them in 10 minutes of seeing them, right? I mean, your average therapy session is probably, what, 45, 50 minutes versus your average doctor is booked 15 minutes out, right? It's, you know, trying to apply that medical model to like this whole different process is, it's complex. And like Tabby, you had said a few minutes ago, it doesn't necessarily lend itself to that at all.
Not at all. It really doesn't. I mean, it's a lot different than, you come in with a broken arm, it's a broken bone. There it is. You take an x-ray, broken bone. There you go. But, you come in with a broken heart, and it takes a lot longer to figure out what happened. And, there's a book by Oprah and another gentleman whose name is currently escaping me. But I love the concept of it. The question is, what happened to you? And it takes us a while to unpack that. People are coming in to this perfect stranger to talk about these soul level things that are sensitive and things that we need to honor and go slow with. And the medical model doesn't allow for that. They might say you only get so many sessions, or, so much of this. And I know, we all have thoughts about, them restricting the number of sessions. If you come to me and you've been in a domestic violence situation for 25 years, you didn't get there overnight, and we're not getting out overnight. It's going to take a little bit of time.
Right.
And to be able to have the time and space to walk beside someone in these dark places and walk them out of that, I call it the valley of the shadow of death, into the light, takes a minute. And the medical model just doesn't even account for that in any way.
Right. Erica, you had a point that you had brought up to me earlier about it kind of diminishes the client's ability to utilize relational healing. You want to talk a little bit about that?
Yeah, I think it piggybacks on Tabby's point just now of I tend to think about therapy as being a balance of art and science, and we're trying to work within a system that values science, or is attempting to value science. And so I think that, I've not met a single client that hasn't had a relational trauma or an attachment injury or something somewhere along the line that they've experienced in their childhood with their parents, with their partners, with somebody an hour ago, right? Those things are very real, and we can actually help our clients by bringing attention to that and being able to focus on our relationship with the clients. There's immense healing that happens through that experience alone. And if we want to go the science route, we know it's 60%. 60% of outcome is based on therapeutic alliance.
Right.
And insurance companies are whatever. Did you reduce their anxiety by X amount in this amount of weeks? And that's really what they're looking at. And to me, that sort of makes sense. They have to base what they're going to cover on some outcomes.
Sure.
But I just think it's at a detriment to our clients, honestly, and to us as therapists to not have the freedom to explore some of those things.
Right. It kind of takes that whole square hole, round peg kind of, we're trying to shove it in there, right, and make it fit a thing that it doesn't necessarily fit. So.
Right. And we have this other problem where when insurance is dictating what's covered and how many sessions a person gets, that then you have this insurance company, a corporation, that is making treatment decisions that should be in the hands of the licensed mental health professional who determines, are we making appropriate progress? Is this the correct number of sessions for this person? What actually are their needs? Those decisions are taken out of the hands of the person who has the training and qualifications to make those decisions, and the decisions then get made by some kind of algorithm.
Right.
Or what the insurance company has deemed the lowest number of sessions to feel like we met our obligation.
And I think that also has a lot to do with the difference between true healing that is possible in therapy as opposed to the alleviation of symptoms. And there's a big difference between the two of those things. And the medical model promotes the alleviation of symptoms. But we know in the true deep healing that happens in our rooms and in our spaces that, oftentimes someone will come in with what they perceive as the problem or the symptom, and it's just the surface level of what's truly going on. We know that with trauma, we know that with relationship. So, just across the board.
Right. You had touched a little bit, Yolanda, on a few minutes ago on caseload, insurance reimbursement, caseload for providers, and how it kind of, I think you were kind of going down the road of it can kind of overwhelm or create a situation where you're working too hard as a provider. You want to talk about that a little more?
Well, it for me, and I was on insurance panels in the past, and I decided to come off of them for several different reasons. One was that reimbursement continued to go down, and that just is in stark contrast again to the fact that these insurance companies are having, profitable years. It also, I recognized it was causing me to compromise the quality of the work that I was doing and the depth of the work and the healing that I was able to be present with my clients for. And as a trauma therapist, if an insurance company is decreasing my reimbursement by 30%, and my option is to increase my caseload by 30%, and trauma work takes a toll. I mean, it's deep work. Then that was causing me to compromise how I was showing up in sessions. And that just wasn't okay for me. It was compromising my ability to return phone calls, to people who had reached out for help. It was compromising my ability to make sure that I was prepared going into the next session. It left me very little time to even just run to the bathroom and maybe grab, a snack or something, a drink of water before jumping back into the next session, not feeling like I was able to be as prepared as I wanted to be.
Right. And how do you do your best work when you're always on the back foot?
It wasn't possible for me.
Right.
Well, and I think we're asking clients to take care of themselves, and we're responsible for helping them to step outside of themselves. And what are we modeling by running ourselves into the ground and overworking and trying as quick as we can to eat something and run to the bathroom, but we want them to be self-actualized.
Right.
It's pretty hard.
Mm-hmm. Yeah. And in trauma work, it's necessary to be the calm presence in the room. And when I'm scrambling, between session and session, that's the therapeutic use of self. That's the depth of how we, are present to our clients. And so if I'm not able to bring that into a session, I'm setting myself up for failure. I'm setting this therapeutic relationship for failure, and I'm setting my client up for failure. And I just couldn't do it anymore.
Right.
And it really limits the length of session also, because they will not pay for anything over 60 minutes, and they really argue about 53 to 60 minutes as it is. And I have found, especially with complex trauma and using EMDR, we need longer sessions, and we need to be able to go slower to help people process. So it's not uncommon for me to do hour and a half, 2-hour sessions, even intensives, where I spend several days with a client and do work with them so that they can get through what they need to get through. It's a terrible thing. And I also took insurance at one point to say, hey, we're at 45 minutes. I know we're right in the middle of processing this major thing, but let's box it up and I'm going to send you home.
Right.
That just didn't feel good to me.
Yeah.
Right.
But my commitment up to them up to that point is I'm here with you in this, and we'll get through it together. And then to say, oh, our time is up.
Right.
Not cool.
Any other thoughts on the medical model before we shift gears?
I just want to say that it's not universal that if you're using your insurance to get therapy, that means that you're going to have a bad experience.
Sure.
We're just talking system wide, that there are some issues with this being the primary way that people access therapy, and that the choices about how long the sessions are, how much they get paid, who makes those decisions are kind of in the wrong hands.
Right.
Mm-hmm.
Absolutely.
Yeah. And
Right.
I think it's important to that point, Becca, that, if we want people, part of what we're doing here is we want people to understand some things about mental health and about therapy and what options there are out there. We would love it if there were an uprising, if you will, maybe that's a strong word, of people calling legislators and insurance companies and going, this isn't okay. We want help. I don't begrudge any organization making a profit. I begrudge it when it's at the expense of other human beings.
Right.
And that's what we see with the model. And so there are amazing therapists that have an insurance-based practice who are doing incredible work. What we would like to see is, if you have insurance, we'd love to be able to take it and do it in a way that you get what you need from, all therapists who take insurance. And And I think that would be, if we could have anything, that'd be the outcome, right?
Sure.
That this is done well.